Okay, thanks, Dirk and PK, for the invitation. So Ultrasound Access, how I do it. I think this is a great discussion right after that demonstration. These are my conflicts. So tibial access has really become a required skill set in the treatment of critical limb ischemia and critical limb intervention. Ultrasound guided access, I think, makes the process safer and more effective both for you and the patient. And I was just overhearing a conversation from interventionalist and EP guy talking about how this has become standard of care, and I strongly agree. So for me, access is 100% ultrasound guided, except for radial stuff, but any kind of groin access, tibial access is ultrasound guided. The advantages, no radiation or contrast. You can avoid the veins. You know, he said you can have 2 veins, but I've seen up to 5. And I think in this case, there was actually more than 2. You have real-time visualization of the vessel. So, you know, if the vessel rolls, you can see it. If you do contrast and roadmap, the patient moves, the roadmap's useless. If the vessel rolls, you don't know it's doing that. So under ultrasound, you'll see that. Patient motion, not an issue. You can actually visualize the wire traversing. So we use the ultrasound not only for access, but actually to guide our intervention a lot to see if the wire stays within the vessel lumen. And you have higher first attempt access. So this is the equipment we use actually in our outpatient lab. It's a mobile sort of GE unit with a hockey stick probe that he described. So again, when you first start this, what I recommend is starting with groin access, okay? Or if you do venous ablation, you have experience with that, but do it on every groin access. It's basically like tibial vessels, but just larger. You can practice long access and short access. Have patience. So if you have a tech available to you, I think that's helpful in the beginning, especially if you don't have ultrasound background. But have patience to get the best image, to really visualize both the vessel and the needle going in. We talked about this, so I believe in keeping the access as small as possible. Most of the time, I'm just using the either sheathless or a 2.9 French Cook sheath, gaining across the CTO and then reversing it, delivering therapy from above. In some cases, we do upsize and deliver therapy from below. You can either do a drip or flush it, every 10 minutes. I try to keep my ACT over 250 if I'm doing tibial access. If you have the choice, I do like to access the posterior tibial a little bit higher above the communicating artery so that there's still flow from the peroneal into the foot. And also that area is usually a little straighter for these patients who have a lot of calcification and tortuosity right behind the ankle. I believe in imaging after the sheath is removed. So if we do a TAMI procedure where we only have ankle access, I ultrasound it afterwards to make sure that we haven't damaged the access site. And it's important to train your staff on hemostasis. So most of the time we're doing manual compression, but it's still important to see. I have seen, the compartment syndrome develop even from an ankle stick. So it's important to examine the leg afterwards and know what to watch for. Hockey stick is great, small footprint, higher frequency. It gives you really good pictures of superficial structure. So anterior tibial and posterior tibial arteries is really nice. One thing, when you put the bag over it, don't put a ton of gel in there, just put enough. And really try to have the bag tight over that, taut over that, so there's not a lot of redundant bag. Because when you stick it, sometimes you don't realize it, but you'll stick through the bag. Linear probe, definitely for the groin, and for my peroneal access, I use this most of the time because that is typically a little deeper, 3-4 centimeters. Just optimizing your image. So image depth, on the left is a little bit. There's no reason to image that much tissue, so bring it a little bit more. The depth more appropriate. Set your gains appropriately. Remember that the ultrasound beam is a thin ultrasound beam. So you saw the 2 approaches, short axis. And again, my preference is long axis. But in short axis, when you bring the needle in, if you close the angle between the probe and the needle, it's very helpful, I find, because it gives you a little more time for that needle to be in the field of view of that ultrasound beam. So instead of, in and out, a white dot, you actually see more of a linear needle. It's easier to follow, and it also gives you directionality of the needle better. So again, you have to visualize the tip of the needle in this to really make it work well. In long axis is very different. And again, if you have a tech, I think this is much easier because they basically just have to give you a picture of the artery. Okay, you want to see the top wall, bottom wall, tell them to keep it there. I want to see a lead pipe. Okay, my job as the operator is to come in and I look at the probe, I stick behind it, make sure I'm not on the bag, As soon as it's under the skin, I look at the screen, and my job is to advance the needle, and I want to see the needle advance as I'm pushing it. Because if the artery's in the view and the needle's in the view and it's moving, it's all along the same plane, okay? You get down to the artery, you tent it down, you advance it, it goes into the artery. If you push and you don't see the needle moving anymore, it's because you've gone either lateral or medial. You have to stop, pull back a little bit, readjust very fine movements, and then advance again. These vessels are not like radial vessels in the fact that they are very diseased typically. Here you can see this vessel was wide open, but typically they're diseased. If you do have a diseased access, I always use a V18 wire because I think that's a good wire that tapers very quickly. You don't need a lot of it in to get a sheath in, hydrophilic. But one thing that happens is when you access it, a lot of times it'll pop onto the posterior wall, and you have to pull the needle back slightly to get the wire to advance. So when you advance the wire, don't push too hard because you'll probably meet some resistance. So again, here's some advice. Bouncing the needle once it's in helps you visualize it. Have someone else watch the hub of the needle for blood so that you can keep your eyes on the screen. So here's just an example of bouncing needle that helps see the needle. Here's an example of how hard you have to push sometimes to pop through. This is a vein on the right, so it shows the movement a little bit more exaggerated, but tapping while you retract the needle to get the wire to advance. I don't do lidocaine typically if it's a tough stick because once you give lidocaine, a lot of times your image gets degraded. So I'll do that after I get the wire in. Here's a calcified rolling vessel in short axis on the left and long axis on the right. You can see shadowing on the right. If it rolls, you just have to adjust. Sometimes if it really is bad, you can actually leave one needle in place, bring another needle in sort of at an orthogonal angle so it's pinned up against that first needle. So access, it can be anywhere with ultrasound. Here's a occluded SFA stent. I do it under ultrasound, but again, here's what it looks like under fluoro. You typically go 30 degrees. Remember, this is an occluded stent where you can see the catheter was going behind it. I'm running out of time here. You can actually access occluded arteries. So here's the dorsalis pedis that's occluded. We tried to get into the dorsalis pedis to get around the heel. This is what the vessel looks like. It's nice, and this is the typical one that we like to access where it's dark inside, not super calcified. This is what it looks like with a V18 wire, a CXI catheter behind it. Make a small loop just like we do in the SFA, advance it into the reconstitution point. You can see the injection. We can access digital arteries. So here's the train track calcification here, my needle coming in. And you can actually see the vessel kind of follows it as I'm pulling the needle out. That's what it looks like. There's a pedal reconstruction. You can see that we got digital access and medial plantar access. Prolapse the V18 wire to get in there. And that's what the result is. Just the last slide, complications. If you see this, okay, there's no bleeding, but be aware of this sort of diastolic compression because this is an overlying hematoma or worse, a pseudoaneurysm. And so you definitely want to image that by ultrasound and take care of that. So again, it can be done with ultrasound or fluoro, and you should be accustomed to both. But I think ultrasound offers many advantages, and I think it's a skill set worth mastering. Thank you.